Hey, I have a question for you.
Okay, are we set? Thank you. Well, okay, sorry, my apologies. Good afternoon, everyone. Today is April 22nd, 2026, and it is 4:07, I have here on my phone 4:10 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. And for public communication, I believe we do have a community member. So, and
Yes.
actually, we will take that community, do we only have one member who signed up? Okay,
Yes,
for
Chair, we have
both?
one at 4 p.m. today.
I'm sorry?
Yes, Chair, we have one person signed up to speak at 4 p.m. today.
Okay, perfect. Go ahead, Yasin, read it.
Okay, thank you.
Thank you.
So this evening's public communication guidelines are as follows. Please introduce yourself by name before beginning your comments. If your comments will focus on a specific item or issue on the agenda, please indicate the full item number. After your introduction, each speaker will be limited to 3 minutes. Staff will be timing each speaker. We'll announce when a speaker has reached their time limit. Once we have let the speakers know they've reached their limit, we'll allow 30 more seconds to wrap up their comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. I do have Daniel on the call right now, so I am gonna unmute, and he actually just called in via phone.
Okay, welcome, Daniel.
All right. Hi, my name is Daniel Martinez, and I'm waiting to find out from y'all what's on the agenda before I start. Because what I had to speak about, it may not be on the agenda. So
That is
I was
fine. You
gonna
can
talk
speak on
about-
whatever matter you would want, but we cannot
Oh.
discuss anything that is not listed on the agenda. So feel free to speak on whatever subject matter you would like.
Okay, I want to speak on the mental health issue with these community clinics. I have what's diagnosed as where you just say things without thinking and not knowing your audience or who's around, impulsivity. But what I would like to see more as far as the mental health through the clinics is I would like to see where the doctors or somebody from the clinic in the mental health area check in with their patients at least once a week to see how we're doing, if we need anything. I would also like to see happen once a week or once a month, put everybody together for like a group, like it could be bipolar group, it could be whatever mental health group, which would be run by peers, like myself. I'm a peer specialist with the, I'm independent right now, but the meeting group would be monitored by somebody that's in the mental health area. It doesn't have to be the actual doctor. It could be somebody to monitor, to make sure that we don't say things, that would, whatever. I don't even know who I'm supposed to be seeing because nobody from the mental health has ever contacted me to find out. Because I was seeing Erica Schuler, but she left, and I haven't heard from anybody since. So, that's what I'm That's all I got to say about the mental health area. What I would like to see done in that area.
Thank you so much, Daniel. Yesenia, can you please take Daniel's information and we will have a staff member follow up with you?
Okay. Sounds good.
Thank you so much and appreciate you coming this evening.
Thank you.
Have a good one.
You too.
Does that conclude our public communication?
Yes, this concludes this evening's public communication. Thank you.
Thank you so much. Well, members, before proceeding, I want to take a point of privilege. As you all may know, April is Arab American Heritage Month. As an Arab American myself, and this is a month that really honors and represents folks in our community. And surprisingly, that I just found out that we only represent 1% of the United States population, but yet we are part of the society. We're leaders, we're educators, we're teachers, we're doctors, we are everywhere. We are neighbors as well. And we have been fortunate to be part of this fabric of this community, and I believe in representation. So it's grateful that we're here today, and with everything that we represent, our big, beautiful eyes, I guess, but our, the culture that we bring to this community. And I really deeply appreciate the Travis County Commissioner Court for recognizing and acknowledging this month. And I also want to recognize all our staff workers throughout our enterprise with Central Health, Community Care, Sendero, everyone who is representative of that culture and community. And we appreciate you. And thank you all for giving me this privilege. And now, proceeding with our agenda, I will take on agenda number 1, approve the minutes of the February 25th, 2026 Budget and Finance Committee. I move that the committee approve the minutes of the February 25th, 2026 Budget and Finance Committee meeting. Do I have a second?
Second.
I have a second. Any discussions around the consent agenda, members? I see none. All in favor? Aye. Thank you, and Dr. Brinson is aye. So the motion passes unanimously. So I am gonna take agenda item 2, discuss and take appropriate action on the contracting with community-based organization policies. And agenda item 3, discuss and receive an update on Central Health fiscal year 2026 costs related to community care health centers. Members, I announce that the committee is convening closed session to discuss those agenda item 2 under Texas Government Code 551.071, consultation with attorney, and agenda item 3 under Texas Government Code 551.085, governing board of certain providers of healthcare services. And it is April 22nd and 4:18 p.m. Thank you. Edwin, are we good? Well, still good evening. Today's still April 22nd, 2026, and it is 5:13 p.m. We are coming out of closed session. We are going to be discussing agenda item number 2, our CBO policy. So members, I know that you all received the policy in hand, and I do not, and there hasn't been any changes to what we have reviewed. Based on that, is there any suggestions to modify or any recommendations to add or delete to a current policy we have? Manager May.
Thank you. Managers, I would respectfully ask you to look at page 16 of the red line policy. I think in the packet, you had the one that had been worked on, and what was to be presented. But I wanted to call your attention to the red line policy. And here's what I would ask you to consider. Under page 16, item 5, it's, basically reads this: do not exceed the approved funding sources and amounts identified through the annual budget process. And we had crossed over the amount of 5 million in any fiscal year for the cumulative CBO funding allocation. I'm not sure how we lost that ceiling of the 5 million, but I would ask us to consider reinserting that language of the 5 million ceiling. And the purpose or the reason for me, the rationale as I'm seeing it, is because if we don't put it in our policy, and if we just wait till the annual year when we're doing our budget, we can so easily get lost with that number, and we won't have that number included in there. I think it's important that as we're moving in the future of our healthcare system, that we have some caps and have ceilings on some of these program spendings that we're doing. I'm not suggesting that out of the list that we had, that anything come off. I'm not suggesting their funding allocations change. I'm just suggesting that we have a limit to the number that we would invest in our community for the CBO policies.
Thank you.
Yeah, so that's it.
Thank you. You answered one of my questions. So currently, members, you have a list of the current CBOs that we currently fund, and the contract amount is roughly over 4 million for this year. So my question to you and to all board members, if we would add that limit, would that be inclusive also with the current CBOs that we're currently funded? And I know we also have the prerogative to make any changes, to amend these contracts, or to terminate these
Correct.
contracts as well. So
Correct.
what your suggestion is the total period for all CBOs up to that amount? Is
Up
that
to the 5 million. And the reason I use 5 million is because I wasn't real sure what the total amount of funding was for all our contracts or how many contracts we had. I knew it was in the vicinity of the 4 million. I thought it was actually higher than what it appears here. But I think that the 5 million is a good, safe number to start with. And it doesn't, as I said earlier, this is not to suggest, unless staff finds that they're not meeting their objectives and that the outcomes are not being measured, or they're not coming out in a manner that reflect what the contract stated. I'm not suggesting that we take any of these individuals off the contract list at all.
Thank you for that. My question to Jeff, and I see Dr. Martin has his light up. So Jeff, the way how when you plan our 5-year projection, so this proposed 5 million will be compounded over 5 years, so the total, we're looking at 25 million? Is that how it works?
Yes, year over year, it would have an accumulated cost plus an inflationary amount. We typically have an inflationary amount too.
I missed that, but what is
Yeah,
that?
can you repeat that, please?
Yeah, so I think let me make sure I understood the question. The question is, if we have a $5 million amount in a base year and we're doing a 5-year projection, we keep that $5 million in every year. So over a 5-year period, that would be ongoing costs that would total $25 million plus an inflation factor over that 5-year period.
So I want to caution you as well on that. And as we're planning, our budget, we typically plan on a 5-year period. So just wanted to let you know in terms of, we want to be very mindful of our tax rate and whatever implies for that amount. Because if that's what's in our budget, we need to fulfill it, to figure out a way how we'll be able to pay for it technically. So I just wanted to let you know that 5 million is not just 5 million, and as we plan in over the course of 5 years.
Can I make another comment? And I'll make this brief. There may be things that Central Health elects to do that maybe a CBO is doing. There may be things that Central Health is currently doing internally that, for whatever reason, makes more sense to have a CBO do it. Because to me, it's kind of a prioritization, and if you're sticking in a dollar amount or a cap, it could have some limitations to the board as we think about trying to move forward and evaluate some of those considerations, that you may be limiting yourself in that capacity, or we may have to come back in and
But we can
amend
always
the
come back
policy.
and change the
Yeah,
policy.
well, that's another option.
See, that's
too.
the given, is we can always come back and change this, because we know we have it in place. The other thing I just wanted to say too, with respect to these programs, and, while it's still a long shot, because we're not there yet, it is potentially an opportunity, once we set this up, that we might be able to move these over to the foundation when we have the foundation set up. That's the other potential, where they should have better opportunities to grow what they're doing. But let me just stop right there, because we don't have a foundation yet.
Well, yeah, great vision. Okay, thank you, Dr. Martin.
The issue in 5.78 on page 16 is sort of including specified performance criteria. I have yet to ever see those. We're just going to hand out money, and really, I really want to see concrete evidence of what's happening with the money. This is we're getting requests from all different organizations for funds, and these may be valuable, but we need to find very specific metrics on our return on our money. And I would ask that any organization requesting dollars should submit those metrics so we can then follow, and we agree that those are metrics we wish to follow.
I definitely agree with you. I think as we're preparing for the next budget season, it will be helpful for the current CBOs that we are currently funding to see those metrics. And those are some of the metrics that you're already collecting. So at least that we have that information, and we as a board can assess the direction that we want to move forward. So if that's possible to be provided to us.
Okay, since we're in open session, I just want to make a comment. So we're not just I get what you're saying. We're not just handing money out. We are contracting for services. I just want to make that distinction.
I appreciate that. I just want to make sure that we have some data coming back as to what is happening.
So at least whatever data is being shared with staff, that you can share with us on these contracts that we have. Is that, Nakia, is that included in our policy? And I think it's under 7?
It's
Number 8. So just to make sure, okay, so we have that in our written policy with that. So before I move forward with any questions, I have a question to the board. Manager made a suggestion about that 5 million ceiling. I don't know, David, can I take votes on that? Because if the,
discussion on.
yeah, so could that be a motion to amend? So Manager made a motion to amend the policy to include the 5 million cap. A discussion on that. Is there any discussion?
Second.
Ask for a second.
Oh, yes, sorry. A second. So Manager Jefferson seconds it.
Okay, I'll second it for purpose of discussion.
Just for the purpose of discussion, because you mentioned it. Sorry for putting you on the spot.
Okay.
So it's open to discussion. Chair Rodriguez, I see your finger.
I support putting a limit on the board, especially right now, and as Manager May said, we can always change it. I think the other part is, whether it's number 8 or somewhere else, I would encourage us to, ask for a report back from those that we grant. It's very typical to get a report back from, individuals that we contract services for in so many different organizations, so it's not a big, ask to do that, or a big, burden to do that.
Thank you for that. The discussion was just around the 5 million. I appreciate it. So just wanted to go around the room. If anyone has any discussions or concerns about that amendment. Manager Kitchen?
No, it wasn't about that. I didn't want to, since we're in open session, I know none of us are implying that we're not getting performance information from these.
No, we're
folks.
not implying, we just want it back to the board. The staff is receiving that information, and we know that. So any further questions and discussion on that item, Manager Jefferson? On the 5 million?
On the 5 million, so the policy under, I guess, the new number 5 talks about the CBO's contracts and so forth being procured in accordance with applicable law and district-adopted procurement and contracting policies. And so it sounds like to me, there's a desire to see those before they are actually awarded. And if that's I'm trying to figure out what's the reason for having the ceiling on the 5 million. If you want to see what it is and see metrics, maybe those contracts should come here, because right now, they're not necessarily coming here, and I'm sure some of them are differing amounts and may not rise to the level of, needing board approval, but I don't, to put a hard ceiling on something because we want to make sure that there's accountability, well then, how are we seeing it to make that assessment of accountability anyway?
Well, that's a valid point. Manager May?
I was just gonna say, it's not just about the accountability, it's also to begin for us to be very mindful of our budget as we're moving into much larger acquisitions and/or services as we move forward. It's trying to be prudent with our dollars. It's in addition to that. But you're right about the accountability. There's ways that we can get the accountability. I'm not questioning accountability whatsoever. I think that all these programs are probably doing fantastic work for us. They're right smack in the communities that we need to be in. So I'm not questioning that. It is more about having a ceiling on that amount.
Manager Kitchen?
Do you want him to go?
No,
Did you wanna go?
please.
So, I'm a little uncomfortable with it just because we haven't done our budget yet. And I like the idea of a cap. And from what we know right now, at this point in time, 5 million seems reasonable. But it just seems a little out of order for me to put in a policy right now, to put a cap when we haven't had our budget. And so that's my only unease about it.
Yeah. Thank you. Manager Motwani?
Just a couple of things to say. One, as a sort of perennial nonprofit staffer and professional, I always get a little heartburn when I hear sort of a delineation between grants and typical contracts, because, though of course contracts that are executed with CBOs are often referred to as grants, they are not a free lunch. It is not a gift in a vacuum. Typically, a grant is a contract for a return on investment in services. And I just want to make it really clear that, I feel that way, just to speak on behalf of the health and human service nonprofits that are doing God's work out there. And then secondly, I do, I don't have a problem with the cap. I mean, I think we're moving into an epoch where we need to be mindful, and I think we could just, I am sensitive to the point that Manager Kitchen made that, we haven't done budget yet. And I also know that when we're doing budget, we'll all be here and we can simply just revisit it and adjust it if needed, the policy, which I think is kind of maybe by design, requires that one extra step that's not prohibitively inconvenient, but that does kind of make everyone think a little bit. And I think that's kind of what the notion of the cap is.
So you're in favor or not in favor, sorry?
I support the cap.
Okay, so,
I just want one more second.
yes, sure, Dr.
Yeah,
Martin.
So I would like to say, I'm in favor of the cap as well. I mean, since '24, this has been a ninefold increase. And I think we need to have some,
So-
barrier. And I think of the idea Ms. May said about, as we hopefully transition to more, some of these to philanthropy, I just think that a cap, I understand Manager Kitchen's point very well. We haven't done the budget yet, but we need to look realistically what's happening to the expansive needs on this board.
Yeah, Dr. Brinson, do you have a comment?
I support the cap. And I recognize that we haven't done budget yet, but it gives us a chance to look at all this before budget starts, and then we may have to relook at it during budget.
Yeah.
Thank you for that. Now, I don't know where the 5 million came. Is there, and also I want to ask, in terms of buffer, do you think that is a little bit high amount comparison to where we're at? So would you consider going?
Well, I was the one, if I may speak to it.
Yes, go ahead.
I was the one that put in the 5 million, that I requested 5 million. I was operating off of what I understood was the total grant amounts that we have.
Yes.
And in my mind, I thought it was closer to the 5 million than what we see here. And then too, I thought that would be, thinking that it was the closest to that the current expenditure was closest to the 5 million, I thought it'd be a nice way to wrap it up. But even with what we have here, if we do a 5 million, you're still giving some room for growth if necessary, or some room for any of these other nonprofits. I don't know what their intents are,
Okay.
just moving along the
So
line.
you do not want to amend that amount?
I'm
based on the number.
comfortable with the 5 million.
Okay, no, just, that's because
if-
it was your motion, so
Yeah.
I'm gonna take votes around if anyone wants to accept that. Manager Kitchen, quickly. Do you-
Just wanted to say something real quick.
Yes.
I'm fine with the change and I'll vote for it. But the other reason it makes me uncomfortable is because when I think about nonprofits, we're paying them for a service, and we're paying them for a service for our patients. And to me, it's not like they're an other, not that you guys are suggesting that.
No,
It's
no,
just that,
absolutely.
from my perspective, I don't, either we're gonna do it, or we're gonna contract with someone else to do it. That's really the way I think about it. And to me, it's really more about who's better situated to do the service.
Okay.
So, it doesn't make sense to me to cap it, but I will go along with it.
Thank you. Okay, so managers, I think we know, this is a policy. At any time, we can amend the policy. So let's give it a try. I am gonna take some votes around to see if they accept the motion of that edit. So all in favor of capping it to 5 million?
Aye.
Aye.
Any abstentions? So all,
Motion passes.
the motion passes with one abstention. Okay, so, any further changes to that policy, members, before we move on? I know we're running out of time. So, you're all fine with the current policy? Okay, then, thank you. Thank you, Nakia. Now, moving on,
To vote on the whole policy. You just voted on the amendment to the
it's gonna
policy.
be on consent for the Board of
No,
Managers.
But
You
you
have to
didn't, the
vote on
committee
the
didn't
entire
vote on the
policy.
policy. You
Oh,
just voted
okay.
on the 5 million.
So I will take a motion. Manager May, can you read the motion?
Certainly. I move that we accept the policy as presented with the amendment of the $5 million as presented by the board, or as presented by the
Do I have a
committee.
second? Dr. Martin seconds. Any discussions? None. All in favor?
Aye.
Aye. It passes unanimously. Thank you. We had no motion on agenda item number 3. Now, moving on to agenda item number 4. It's, received the February and March 2026 financial statements for Central Health. Nikki Riley and John Morgan will be presenting. Nikki and John, I know, is John here? Yeah, so if you can make it really short. And I also had a question, I'm not sure if you want to take it now, it's related to the contracts. Would you prefer to present, or do you, go ahead and present your slide, and then I can ask you that
Okay.
specific question.
Nikki Riley, Deputy CFO. I can be very quick. Nothing remarkable happened in March to actually discuss. It is business as usual. I think I've put on the highlight page what has been asked in the past. But if you have any additional questions on our direct services, John will be happy to answer. And other than that, I do not have anything to go over.
Thank you, appreciate it. It might be a question, I don't know to who. You sent us an updated list about the contracts today? Was it an email today or last night?
Which list is that, would that be?
That sounds like us.
It was a PDF file. It had some green lines. So yeah, it is, so that's the monthly contracts
That comes
report.
from
So I have a
purchasing,
question
yes.
related to that.
Okay.
And I know this is something that we have not set parameters, but just trying to think about, so is it typical practice that we have a staff to execute a contract of 28 million? Like to sign off? So that's my question to you.
I would have to look at it. I'm not sure which one that is, if it's a renewal or if it's an original contract.
Is this it? No, it's 26.
It's 26. Sorry, I'm looking at my phone. So that's my question to you in terms of that high limitation. So I'm just want to understand the process, the signage, like who does it pass?
I would need to look at it. Renewals are automatic.
Chair, which contract are you referencing?
I am looking at, it is, sorry, it's a real estate contract. Did you get the email from Brianna?
Got a lot of emails. Just tell me,
I don't think I did, but
can you give me the file name?
I get behind.
Do you have the
It actually
vendor?
does not have a file
manager?
name, but they said it's a monthly contract report.
Okay,
It's
well,
a PDF, so it's Jeff, it's the first time that it's the first time that I received this file.
I'm going to take a guess, but as long as there's a budget that's contemplated, this sounds like a capital budget item. It
Yes.
sounds like the hiring of the Colony Park GC. And that is a big number because it's a CMAR type contract. So it is a large amount. The Central Health Board approved the budget for Colony Park, so it was contemplated in the budget. And that's kind of the bylaw
Okay,
aspect of it.
thank you for that, and I think, Chair, I think we would need some discussion in the future in terms of that ceiling amount. I know we approved it in the budget, it's been approved, but just for a staff member to execute that large amount, even though we approved it, I think we just need some additional oversight from, on a board's perspective, and that's why giving the significance, so that's really it, so it's for future conversation, discussion. Members,
Noted.
do you have any questions related to Central Health's budget for this month?
No, but I request that the board liaison email account be used because I don't remember, when I get emails from different people, it's hard for me to organize things.
I completely understand, that's, I've been having some issues, okay. Yeah, and I think this was the first time that it was presented to us, I have seen it that way. Okay,
yeah, it was sent by board liaison. Yeah.
So okay, perfect. Okay, thank you all so much. Now moving on to, and there's no motion for that, correct? No. Item number 5, receive the February and March 2026 financial statements for community care health centers. Joy Sloan. So again, I apologize for running out of time, so if you can make it sweet and short, that would be great. Thank you.
Yes, do you have the presentation? So for March, our fiscal year-to-date surplus is about 6 million. March, we did experience a slight loss in operations because we had a lot of providers off on spring break, which we really want to encourage time off. But it did drive down encounter volumes a little bit in that particular month. And we also saw kind of a more shrinkage in our pharmacy revenue margin. Revenue came in a bit lower. And so between those two combinations, we ended up with an operating loss, but still a very healthy $6 million surplus. Next slide. And when we look at the balance sheet, we did see cash go up slightly, so we're about 30 million, about 45 days cash on hand, and our liabilities decreased a little bit. And our current ratio is currently over 2, which is very positive. So for every dollar we owe, we have $2 in the bank. So very nice position to be in 6 months into the fiscal year. Next slide, please. And when we look at encounters, like I said, we did see a little bit of a drop in March due to PTO. We're still running about 18 provider openings, which is about 11% of our total provider ratio. We've seen 4,700 more people this time than last year and about a 4% increase in encounters over last year. So we are definitely growing year over year, which is exciting to see. And our providers that are exceeding 90% of their target, meaning that they're really operationally efficient, we're seeing that climb as well this year. So that is our financial report.
Thank you. Appreciate it. So this question is for Dr. Yagoda, and I understand the importance of taking spring break and, mind and just that mental health aspect of it. But also there's a loss, Is there a way that you can incentivize staff, not all of them to take it all at once, if you stay, maybe whatever financially, incentivize them to stay on to that period of time because they benefit and our patients benefit and the revenue also increase. So is there
we've also thought about this as well. We have a number of ways of incentivizing or benefiting providers who work during off hours. Often that is related to weekends, but we have not put into plan or even crafted a definitive plan about coverage, expanding access during high volume PTO periods, but it's certainly something we could consider. It just hasn't been top of mind for us.
That would be great, because I know for a fact many parents or so decide, during the spring break, they also want to go and seek care, and also maybe it's a time to take their children into the well check. For instance, as a parent myself,
Sure.
I wait till those breaks so I can go to the point, so they don't miss school.
Yep.
So it may be an opportunity there to expand coverage, and that could work benefit both ways, the physician, center, and the patients.
Yep, thank you.
Thank you. Any questions related to this, members? Manager Motwani?
Thanks. I always look at the vacancies and kind of try to, or the wage bump that we get in surplus, which on one side is good because net savings, stronger, of course, cash on hand, but then on the encounter side, so that still means it's less encounters, right? So we had more encounters year over year. Is that the metric we're looking at, or are we looking? What is the goal of encounters this year? how do we do against goal? I mean, like,
We're exceeding our budgeted, no, we are,
No.
forgive me. I'll let you, give the detail.
So, yeah, so we are under budget for encounters, in part because we have open provider positions, and in part because we do have capacity within existing provider templates. We are over prior year metrics. So while we're seeing growth, we're not necessarily seeing growth at the pace that we had planned on when we did our budget.
okay, so, yeah, now, okay, I think I found it. It looks like we're 20,000 encounters down on goal, right? So then, is the surplus we're talking about, is it a good thing? I mean, like, so what would that, what would the bottom line look like if we were actually doing those 20,000 encounters? Yeah.
A quick point, and I don't have the exact numbers for you, but I know you've asked us
Yeah.
a question before. It is always to our advantage to fill those provider positions. So the savings we get by not paying their salaries is far less than the revenue we would earn if they were working and generating revenue through encounters.
Okay.
So there's no incentive for us to keep those vacant if that is part of the question.
Yeah, no, it's just, but if I hear it like the positive connotation, like we have a nice surplus, like it's not like, to me, I don't know if it's a nice surplus. Like,
It's a
yeah.
double-edged sword.
Okay,
you know,
okay.
And that's what I talk about a lot in our leadership lunches. It's great that we're counterbalancing the loss in revenue with open positions and savings in wages and benefits, but that is not the ideal state we want to be at. We actually want to be fully staffed and producing at a higher level.
And so when we're talking about growth, would it be possible for us to kind of zone in more on growth against goal versus growth year over year in a vacuum? That's helpful for me, because that way I know whether we're, seeing all the people that we need to see, and then whenever we hear about wait times, I can sort of calibrate what that means with the larger constellation of, are we, hitting goals, and like what are the implications of maybe the vacancies, et cetera. Because I'd like to, because if we were at goal with the encounters, I'm wondering what the implications on expenses versus revenue would be, and whether that surplus would be sort of directly proportional or not, or whether it would be a surplus at all. And like I think that kind of modeling helps, because I do envision a world where I know that y'all are going to get to where we need to be with encounters. And so I would like to be able to forecast against that world too. And if we could forecast, given current, expense to revenue ratios, and what that would scale up like with the current, what that would scale up like if we were hitting goal, then I think I would have a more realistic sense of whether or not the overall sense of projections is accurate or not, and then that would also give me a sense of what potential budget allocations would need to look like the following fiscal year. Thanks.
Well, thank you so much. I appreciate it. Sorry for the time, because we're running out of time. Thank you all for your presentation. Now, managers, I know we're running out of time. For item number 6, how long were you planning for the presentation, Nikki? Riley? And Drew, so the presentation, item number 6 is discuss and take appropriate action on the process for board manager proposals for fiscal year 27 budget. Can you make it less? Okay. Because the item, I don't
negotiation.
anticipate that. I don't anticipate us taking a vote on this. This is because this is the first time that it's presented. I would hope that we get some feedback from board members and how we can enhance this process. So just letting you know that you're going to be coming back to present to us. Welcome, Drew.
Yes. I'm sorry.
Yes, go
Okay.
ahead.
All right. So good evening, managers. I'm Drew Kolarczyk, Strategic Planning Specialist. Presenting with me is Nikki Riley, Deputy CFO, but I think you know her pretty well. All right, so moving on to the next slide. We'll start tonight with our mission, vision, and values. These are the framework that guides Central Health's work and are foundational to the annual planning and budget development cycle, which Nikki will walk us through briefly on the next slide. Next slide, please.
I think you've seen this before. You've seen this slide before. This is basically the flow chart of our entire budget process. We right now are in between the green and the UT orange. We're right there. The orange is the business cases that we are going to walk through the process today.
So is this process similar to what was adapted last year? Any changes to last year's process?
The one change you'll notice, which I'm about to share with you all, is there is a short form step, and I'll talk about that more in a second. Okay, so thank you, Nikki. I'll walk you through the process now. All the information shared tonight will also be in a bundle you'll receive later from the board liaison, and there's a lot of info, so appreciate you holding questions until the end if possible. And I'm sure there will be questions. I know we're moving quickly. Okay, so first I'll cover the process, and in a few slides we'll look at the dates. So as a reminder, this is a collaborative process intended to enhance the annual budget development, and staff support is available throughout the process if you have any questions or need help. Okay, let's look at step one. We're staying on this slide. You'll complete a short form for each initial proposal, which we'll look at closer on the next slide, but we're staying here for now. And then that will be submitted to the board liaison email address. Moving to step two, the board will review all submitted short forms and determine which move forward to develop full proposals, so that will happen in a meeting. In step three, full proposals use an A3 format, so those who were here last year, you're familiar with that, which you will see a preview of tonight. You can include additional information if needed. That is also submitted to the board liaison. Finally, in step four, a staff level review team assesses all proposals and develops recommendations, which will be shared with the board for feedback, clarification, and collaborative discussion in June before presenting the FY27 proposed budget, again, similar to last year. So those are the steps. Now let's look at a preview of the short form you'll receive for step one. Next slide, please. Oh, we're there. Okay. So I know this could be a little hard to read. Even with glasses, it's tough for me. So this is just a preview of the document you will receive. The short form step provides early visibility into recommended proposals for board discussion, guiding which initial proposals advance to more developed proposals for budget consideration. So let's look closer at this screenshot here. You'll fill out each column in the short form. So the name of the recommending board member, system OKR, I know those are in draft right now, but we'll have the final ones in there for you all when this comes out to you. And a brief description of the problem to be solved, including an estimate of staff and budget. The guidance under number 2 is a reminder that filling out the short form is a starting point in the process and includes in questions from the A3 to consider when filling out the short form. That also helps with discussion that you'll have in this room. You'll complete one short form for each budget proposal and submit to the board liaison email address. And if the board determines that an initial proposal will move forward, you'll then complete an A3 for each proposal moving forward, which we will preview on the next slide. Okay. So this is a preview of the A3 template proposals moving forward we'll use. This is referenced in step 3 of the process that I stepped y'all through. Again, staff are available to support if needed. So the questions you see in each block here are for consideration when filling out and frequently arise during the evaluation process. So you'll have more space than it looks like you have. These are just here to help guide you. So starting at the top of what you see here you'll provide some basic information to help us identify your proposal. Then moving down a row, you'll include the best aligned FY27 OKR, which you should have from your short form that you prepared previously. Then we'll move down to the 4 large boxes, which are really the meat or the tofu of your proposal. So starting in the upper left is the problem to be solved, which can carry forward from your initial proposal, so that short form that we just saw a second ago. Then moving down to the lower left, the analysis box asks for data or evidence to confirm that the problem exists and the underlying causes. Then moving to the upper right, you'll detail the proposed solution and implementation plan or the steps to do the work. And finally, in the lower right, success measures asks how project results or expected outcomes will be measured. So as I mentioned earlier, you can provide additional documentation if needed, and staff are available to support. I know this is a lot of info.
Well, thank you.
Okay, now that we've covered the process and the documents you'll be filling out, let's look at some key dates for this process. All right, next slide. So you will see these same dates on the overall budget timeline on the next slide. I know we're short on time. I can read through these, or we can
Well, thank you for that.
move to questions.
Giving the time constraint, I think this is the first time like the board has seen it. Let's take a little bit deeper dive into this process. Thank you for your work and presentation, Drew. I think this is the first time you came before us to present.
Yes.
Well, welcome, and hopefully more to come. So I would want the board members to look at it a little bit further and to provide comment. I also hope the same process that us, the board, is going through, the staff, like sometimes in proposals. So I would ask for also this to be a similar process applied for staff recommendations.
It is, absolutely.
And for us to decide also if, before venturing out and talking about potential proposals, perhaps vetting it through the chair, the vice chair, or me to see if this is a potential opportunity to move forward. Because I understand the time that it takes for staff to complete this, to meet with other parties. So if it's something we would like to move forward, there's alignment, I would hope that you can continue on, but if there's not alignment, to make it more efficient for the staff and for everyone, let's just go through a similar process. So that's my ask as well. Members, you have this process. I am gonna take one quick question, and we can discuss it later on.
I can send in my comments.
Okay, is there any burning questions on this item?
Can I just make one quick
Yes, Chair.
comment? So, I know, members, we've had some discussions, and I know, our vice chair and I both had discussions about making sure that this process both was not different than last year, but also that it was sooner than later. Just because ultimately the entire budget is our budget, right? We're gonna vote for it. But the sooner we can get these things in, the less work there is at the tail end for kind of speeding through all of the staff work around this. But I just wanted to give that one short.
Thank you, and I think we were really good last year. There were no last minute surprises, and I think it was helpful for the staff. I hope the process that we developed last year, we're not the day of or the moment that we were about to vote, we added any additional projects or proposals that were not vetted. So I think given the time that today is April 22nd, and you want May 6th, so maybe at our next meeting, we will vote for this and push probably or expedite this timeline, just to get more feedback from staff, board members on this process, and if they have any further comments. But I really appreciate the help and all the work that you have gone into this. I think we have surely advanced this process, and it has been seamless, I hope, than it has been in the previous years. Thank you all. Members, I apologize for going over time. This is actually the first meeting on records that I went over time. So I am moving on to agenda item 7, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, May 27th at 4 p.m. Isn't that before Memorial? Are we at?
Yeah, I think so.
Okay, so we'll look at it, we'll see, May 27, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Chair Rodriguez moves. I get a second. Any discussion? None? All in favor? We're adjourned. Thank you.
Members, we're gonna take 10 minutes to go and get dinner and then come back.
Good job.
of downstairs. Good evening. Today is April 22nd, 2026, and it's 6:17 PM. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. Excuse me. As a reminder, some of our board members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. We're now going to proceed with public communication. Do we have anyone that's signed up for public comment? We do not? Okay, so since we don't have anyone signed up for public comment, we're gonna move on to the consent agenda. And I would ask for a motion to approve the consent agenda.
Chair,
Yes.
I'll make the motion, but with the amended, on the, one of the amended, CBO policy that we amended, because I don't think here
Oh,
it
great.
says.
Yeah, so you make a motion to
Approve it with the amended,
Yeah.
policy that we had in budget and finance.
for item C6?
Yes.
Okay, great. Thank you. Members, do I have a second?
Second.
So having a motion and a second to approve consent agenda items C1 through C6, all those in favor, please raise your hand.
Aye.
Say aye. The motion passes unanimously. Members, we're gonna now proceed to the regular agenda. Item 1 is to receive and discuss a report from the board chair. And today I just have two things. One, you will notice that past the chairs where we have the speakers, we now have the 3-minute timer lit up, and it's counting down here, but it's lit up today. I don't know that we'll be using it, because I think we're all, kind of our limits for today around our third publicly posted meeting for the week. But I just wanted to make sure you knew that it was there. Secondly, just a quick reminder that on May 2nd, we have a board retreat. We've had a request by our governance consultant to see if the board would consider moving the time on May 2nd from to 9 a.m. to 3 p.m. with an 8:30 a.m. breakfast. It'll be at the Courtyard Marriott in South Austin. And the team, if they haven't already, will send you the new location. And I think they've also are reaching out to you all to confirm that you can do the different time. But I wanted to make sure and bring that up. Manager Mercedes?
I'm just curious, why is it at a hotel?
I think there was a concern about making sure that we had all the services available to us, and there's free parking there, and it's one room where we're gonna be at. Is that right? Yeah. Yeah, and they'll be providing breakfast where the staff, catering and staff, that the staff is not here on the weekends. Yeah.
Thank you, and, about that time, I have a commitment, so I may be leaving earlier. I won't be able to stay the entire time.
Okay, got it, thank you. And yeah, if you'll let our staff know, Bedla and the team. Members, I'm gonna move on to item number 2, receive and discuss a report from the President and CEO, including the strategic board alignment, clinical excellence, financial sustainability, and people and community. And just before you start, Dr. Lee, I just wanna mention that before we started the meeting, we looked through our timed agenda and tried to cut out about 35 minutes just to make sure we can get back on time. So with that, I'm going to turn it over to Dr. Lee. Thank you. We should have a timed copy on everyone's chair. Bedla, can we provide a copy of the time for all the members? I thought they were on in front of them. Oh, they haven't passed it out. Oh, sorry about that. Okay. They're passing it out. Okay. So obviously the times are a little bit different, but we cut some times off of some of the presentations. And hopefully we'll have all the time we need to deliberate. Dr. Lee?
So thank you, Chair. Good evening, members. I'm pleased to share today a brief high-level summary of key updates from across our system over the past 30 days. And the goal of this monthly verbal update is to provide you and the public with a clear snapshot of our progress, some key highlights across the Central Health System. A list of these updates is included in your backup on page 112, if you'd like to follow along. So I'll begin with several clinical and facilities updates. One of our most important priorities this year is improving access to care for our patients. To advance that work, several of our community care teams have been undertaking a series of special weekend clinics to help work through appointment backlogs, particularly in our dental and women's health clinics. Overall, these have been incredibly successful, with remarkably high show rates ranging from 80 up to 100% show rates for these clinics. We also continue making progress on several important facility and service expansion efforts across the system. Most notably, phase 1 of our Hancock campus is now opening. We will see our first patient at the new David Powell Clinic this coming Friday, April 24th. All right, amazing. Last Friday, we hosted a brief program and tour for key stakeholders to visit the site and to learn more about our plans for what will become the largest one-stop shop clinical care site in the Central Health System once completed early next year. I want to thank Chair Rodriguez and Manager Jefferson for providing remarks and Manager Motwani for attending and support. It was wonderful to have you, 8 of our community care board members, our Sendero Board Director, Libby Doggett, and many elected officials, including Representative Donna Howard, Commissioner Bridget Shea, and Council Members Quadri, Fuentes, and Duchin there to support us. Next, construction on our Colony Park facility.
Sador, were you there? At the, did you mention Manager Jefferson as well?
I believe I did.
Oh, I'm sorry.
But thank you for double checking. Yes, and thank you for your comments at the event. I'm so sorry, Vice Chair May.
It was a running count in my head. It's something.
My apologies, Vice Chair May. Thank you for being there. How could I forget? I actually have a selfie picture of the two of us in hard hat and green vest. So thank you, Vice Chair May. So next up, construction on our Colony Park facility officially began on March 16th, marking an exciting milestone as that project starts to take shape. Once complete, this will be a 34,000 square foot facility, larger than our Del Valle facility for comparison. It's planned to open in summer 2027. It will bring together clinical services, community resources, and support services in one location in a very important part of the Eastern Crescent. And we're looking forward to the formal groundbreaking on May 16th. Stay tuned for more details. I'm also thrilled to share that our Del Valle Health and Wellness Center has now officially been open for a full 1 year. It's an important milestone as we continue expanding access to care in historically underserved parts of our community. Since opening, we have had over 20,000 patient visits take place at this site, alongside many other community activities and events. We're also exploring the range of specialty services available to patients across our system. A couple of weeks ago, several Central Health team members traveled to Salt Lake City, Utah, alongside colleagues from Travis County, the Travis County Jail and Sheriff's Office, and Integral Care for an informational visit to the Huntsman Mental Health Crisis Center, where we had the chance to tour and learn about Salt Lake County's mental health diversion model as we consider the next steps needed to address needs here in Travis County. Moving on to a few financial and operational updates. First, on the financial side, as members are aware, we received a clean, unmodified opinion on our fiscal year 2025 financial audit, a significant milestone that reflects our strong financial stewardship and supports our continued strong bond rating. We are also remaining on track with our budget, with our January financials indicating we are at 29% of our total budget 4 months into the fiscal year. On the operational side, one of our major goals this year is to reduce duplication across the system. We made some meaningful progress on that front this month by retiring a duplicate communications platform in our technology environment, specifically Our Ring Central team texting function has been phased out. We fully transitioned all our group chats over to the Microsoft Teams platform, which is a major accomplishment that improves consistency, helps keep our teams working in a shared platform. A few updates related to our workforce organizational culture. Our Guide with Love leadership curriculum continues to take hold across the system. As of this week, 79% of Central Health System leaders, or 355 out of 457 total, have completed the training. The remaining 102 members are currently registered for upcoming cohorts. And a few weeks ago, I actually had the privilege of connecting with Mohammed Anwar, who is the lead author of Love as a Business Strategy, which is the foundational book for our Guide with Love curriculum. It was an incredible opportunity to share and learn about their approach and our framework, and we'll likely be continuing to explore further collaborations with Mohammed Anwar and his team. Finally, a few community engagement and stakeholder updates. Last Thursday, we held our second community conversation of the year in Precinct 1 alongside Commissioner Trevelyan, and I'll try and get all these names right, Chair Rodriguez, Community Care CEO Dr. Nick Yagoda, Sendero CEO Sharon Alvis, drawing over 90 attendees. So thank you to Chair Rodriguez, Manager Kitchen, Manager Matwani, Manager Jefferson, and former manager Shannon Jones for joining us. Vice Chairman, I don't think you were with us this one. So okay, all right. All right. Did I miss anybody? Okay. Well, thank you all for joining us. Yeah.
Just from the Sendero side, and I don't think this is a miss, but you know, it's always fun to mention a board member,
100%.
Dr. Libby Doggett.
100%. Dr. Libby Doggett was with us. Kimberly Johnson, our Vice Chair of CUC, was with us, and Ms. Barbara Shirley, our most recent member of the CUC board, is with us. So thank you absolutely for that, Manager Matwani. A couple of weeks ago, I was honored to deliver the keynote at Opportunity Austin's Economic Development Council luncheon, where we had a chance to introduce Central Health's work to many influential members of the local business community, really making the point about affordable health infrastructure and the importance of moving care into the prevention space and how that benefits all of us. There were a number of local business leaders and important relationships that we're continuing to build there. And at the end of March, we also provided our Q2 update presentation at the Travis County Commissioners Court, including updates on our FY27 budget development timeline, a summary of our financials, an update on our Mazars performance review, and key system transformation and integration efforts from across Central System. Special thanks to Chair Rodriguez for providing an update to the court on our behalf, and to Vice Chair May and Board Manager Jefferson for attending and support. You all have had a busy month. Also, at the end of March, with help from Vice Chair Lisa May, we submitted a letter of support to Councilmember Vanessa Fuentes' office regarding opportunities for public sites in the city of Austin to be better leveraged to meet community needs. Councilmember Fuentes' resolution on this topic has since been approved by City Council. And we met recently with Councilmember Mark Duchin, who is the Vice Chair of the Austin Public Health Committee, for a productive introductory meeting to help introduce our work. I will be accompanying Councilmember Duchin for a visit to our Bridge Clinic later this week. Finally, our community engagement team continues to do great work across the community, and there are further updates on this that I couldn't cover today on page 117 of your packet. In case of interest, you're welcome to read more about that. And then finally, a news segment here by the numbers, reporting out on some key metrics. So at our next Commissioners Court quarterly presentation in early May, we've been asked to share some data around a few key metrics that demonstrate Central Health's growth when it comes to the total number of patients we serve, the number of primary care visits happening in our system, number of patients covered under our system. We want to preview these data points with all of you today. And so we are on page 114 of your backup. And on the screen as well, you can see first our enrollment data, updated as of 2 weeks ago, which indicates that we have seen a 6.7% growth in our medical access program enrollees over last year, 62,500 approximately in 2025, compared to 58,600 in 2024. Since 2021, we've seen a 34% growth, 46,000 MAP members in 2021 compared to 62,000 now. And though it's not pictured on this graph, we've also seen a 2.7% growth in Medicaid, Medicare, CHIP, and commercial insurance patients over last year, That's 105,000 patients, up from 102,000 approximately last year, as well as a 35.3% growth in Sendero enrollment over last year. Going to the next slide in page 115 in your packet, in terms of patients served, we've seen about a 7.35% growth in the total number of patients we serve across our system over the last year. That's up to nearly 184,000 total. You can see the historic growth over the years. That's a 25% growth since 2021, when we saw about 147,000 patients. There's been an interesting question that's been asked, and Manager Kitchen asked this question just before the meeting. About 95% of patients seen by Central Health are MAP patients, but about 45% of community care patients seen are MAP patients. So we don't have the breakdown on the graph, but that's how it generally breaks down in terms of MAP. And then finally, just the very last slide, next slide, page 116 in your packet, primary care visits. We've seen a slight dip in the last year in total primary care visits, about 1.17%. But recall that this is our network, including Peoples and Lone Stars. Community care has actually seen a 4% increase in visits over the last year, but our total there is down slightly to 670,000 today. That is a 34% growth in total primary care visits since 2021. So again, thank you so much for your partnership support. Happy to take any questions.
Thank you, Dr. Lee. Manager Mercedes from Manager Kitchen.
Thank you. Couple of things while we're on this. It'll be great if you can break it down. I think it would be helpful to know the previous slide, how, because Central Health launched their specialty services, and I'm curious to see how many patients have been receiving care. So if we can separate primary from specialty care, that would be helpful, and that for us to know. Second part, I recently gave a talk about, you know, the overall about health, Central Health, the public health state in Central Texas. And while I was looking at the data, and which doesn't surprise most of us, 40% of Travis County residents, the main cause of mortality is cancer and cardiovascular diseases, heart disease. So I would love to see what Central Health is doing to close that gap in terms of heart disease and cancer, because those are the two killers, primary killers of our residents in Travis County. So if there is some kind of emphasis in how you are working to address this issue, I would greatly appreciate it. Thank you.
I think, could you provide a copy of the letter that was sent over to the city council members, as well as the resolution that was passed, which it sounds like the letter was supporting? I think that would be helpful for everyone to have. And if you sent it, I'm sorry, I missed it, so.
We're happy to circulate that to members.
And you said
Thank
it
you.
passed, right?
It passed, yes.
Okay, and I didn't quite understand what we were doing. We were telling them property that they could use, or what were we telling them in the letter?
No, I think the letter was just being supportive of the process that they
Okay.
were starting around discussions. They were trying to bring, if I'm misspeaking, but for Councilor Fuentes, but I think her effort was try to bring all these parties together to just talk to each other.
To talk about, okay.
About what
I remember,
opportunities
yeah.
there might be.
That's fine, that's
And
fine.
it was, I would submit to you, there was probably a follow-up from that meeting.
Yeah, Mike, sorry.
It was a follow-up, that was the follow-up work resulting from that meeting that they had, where you guys we all came in and presented together with Integral Care. I have a funny feeling that that was part of that follow-up
Oh,
that
you
she
think
was
they were
doing.
following up to that?
Yeah,
Okay.
that was
Okay.
her culmination to take it to council.
Yeah.
To show she had support from all these organizations, and she even included AISD in it,
Okay.
by the way.
Okay, well, just provide a copy, that's fine.
Yeah. Manager Motwani?
Thank you. Glad to see, in the year of access, that, access continues to grow. I certainly appreciate the notion of breaking things down further. I don't want to belabor it, right? But stack bars or whatever we can do helps. And also, you know, that's really salient about the really key indicators around chronic conditions, and you know, seeing how we're performing, particularly, you know, with relation to hypertension, heart disease, and I guess, you know, colorectal cancer screenings, for example, are I think some low-hanging fruit. Not to dilute what I think Manager Musaitis was saying as well, but just maybe to add on to it, that would be helpful. If maybe we could see that more frequently, and I appreciate these updates, and not something you need to recite or anything, but just being able to visualize it is so helpful. Thanks.
Thank you. Managers, any other questions? If not, I'm gonna move to item number 3. And thank you, Dr. Legan. Receive, discuss, and take appropriate action on proposed objectives and key results for fiscal year 2027. And are you presenting? Yeah.
Okay, well, thank you, Chair. It looks like I'm up again for this next one. Managers, today we are seeking board approval of our proposed FY 2027 objectives and key results. Since this item was reviewed at our April 8th Strategic Planning Committee meeting, we have incorporated the board's feedback on our initial OKRs and further, in particular, further defined how progress on each key result will be measured over the course of the year. You will see, in addition, a memo, a late-breaking memo. We got a few excellent questions from Manager Kitchen earlier this afternoon, and with kudos to our Chief of Staff, Nicholas Bustello, for pulling that together in the last hour or so. So apologies if it's not perfectly polished. I wanted to provide additional specificity on some of the metrics. You'll see actually cardiovascular and cancer screening metrics to both Dr. Musaitis and Manager Malani's points. So I'll briefly walk through the major updates to each key result and the measures associated with them. The full FY 27 OKRs will be up on the screen. You can also find these on page 125 in your backup. And there is additional detail there on each proposed metric. Okay, so as outlined in the memo that you all received, we will report our progress against the OKRs to the board on a quarterly basis. However, in some cases, the primary measure is annual. So you will hear me break down some of the kind of quarterly leading indicators that we're proposing reporting out on, even though some of the goals are annual that will be seen on a once a year basis. So starting at the top, let's go to the next slide, please, on the presentation. Again, we're on page 125 in your backup. Reducing appointment wait times to 2 weeks or less. Next slide, actually. This is where we are in space. This is the OKR slide. Great. So reducing appointment wait times to 2 weeks or less will remain the #1 goal, as it has been this past year. It's one of our clearest priorities of the system. People need to be able to get care when and where they need it. And we will measure progress by the percentage of patients seen within 2 weeks across Community Care's medical and dental services and Central Health specialty services that have been in operation for at least a year. So a mature service line in Central Health plus medical and dental in Community Care. Key result number 2, increase the people engaged in care and coverage by 5%. We are on track to serve 1 in 6 Travis County residents by the end of this fiscal year, and this key result is about expanding that reach even further. We will measure our progress against this key result using 2 metrics. Number 1, the total number of unique individuals receiving care within our primary care system or through a billable claim, so that if we are generating primary care through one of our coverage options, we can see the care that's resulting. And the total number of unique individuals enrolled in our MAP Basic, and Sendero coverage programs. Then we will report each of these measures separately on a quarterly basis because we have these numbers quarterly. And then once a year, we will roll them up and do the currently rather painstaking work of deduplicating that number, because some people who receive care are also receiving coverage. And so we will deduplicate for the time being once a year, and that is the number that we report out in the annual report and how we get the 1 in 6 or 1 in 5, et cetera. So that's our proposal for the time being, and we'll work on making it easier to deduplicate as we go, but right now it's a cumbersome process and we want to be accurate. Key result number 3, improving care gaps in heart and cancer care by 5%. So Dr. Musaitif and Manager Matwani, you are right on target. These, as you say, Dr. Musaitif, 2 of the biggest drivers of illness and death in our community. This key result focuses on prevention and earlier intervention, where we know we can make the biggest difference in these areas. Progress against these results we measured using 2 metrics, each assessed on a year-over-year basis to account for typical seasonal variations. So through the year, because of the way the metrics are measured, what breaks a calendar year and so on, there are natural rises and dips. We'll show year-over-year comparisons. First, for the heart care metrics, that'll be community care focused using the standard uniform data set or UDS benchmarks. You've got the details in your handout. And looking at control rates for hemoglobin A1C, that's diabetes control, and hypertension. Second, we'll look at cancer screening rates for colorectal, breast, and cervical cancers in 2 domains. One is community care, where we'll use the UDS metric set. The second is Sendero, where we'll use the HEDIS metric set. So there's different metric sets. They are slightly different, and so we've given you details there. And those are the standards for those 2 environments, so we'll report them out against their standard benchmark. One flag is that we did not yet include a key result focused on behavioral health, since we did hear that suggestion at the last meeting, but not everybody was in agreement per se, and there was not a motion to make this. Should there be a motion and a vote, we are prepared to add that key result here. It would likely be on a preventive basis, likely depression screening would be the appropriate mental health related area, but we'll await board direction on that. Key result number 4, increase employee engagement to the top quartile nationally. This key result sets a clearer, more ambitious standard for the kind of workplace culture we want and must build. Progress against this key result we measured against the national benchmark that is commonly used to determine employee engagement, which actually has 3 components. Number 1, team members' willingness to recommend the organization as a great place to work. Number 2, their sense of meaning and accomplishment in their work. And number 3, their willingness to go above and beyond to advance the mission of the work. And so it's the combination of those 3 that's the standard engagement metric. Our goal is to reach the top quartile nationally. The benchmark score for top quartile is 79.67%. Our current benchmark is 73.84%. So we have that on an annual basis from our Big Listen team survey this year. That's a pretty big rise to get there, but we're going to shoot for it. And to support quarterly reporting, because this is an annual metric, we are developing a quarterly engagement and advocacy index, or kind of pulse survey, that we will have a much simpler version to avoid survey fatigue, and aim to develop that and report that out on a quarterly basis. Key result number 5, to improve guide leadership behaviors by 10%. Recall, these are the leadership behaviors we believe will drive that culture that we're trying to create. We are approaching 400 leaders now trained. And this is about moving from training to measurable day-to-day leadership practices. We will measure progress by developing a baseline, measuring that before the start of FY27, likely through our annual engagement Big Listen survey, and then aiming to achieve a 10% increase from baseline and finding a way to pulse this measurement through the year. The next key result, increasing community awareness, favorability, and trust by 10%. This key result broadens our current community engagement measure to track 3 distinct indicators: awareness, favorability, and trust. Together, we believe these metrics provide a fuller picture of our standing and accountability of the community we serve. We'll measure progress through a brand health composite score that will be derived from our annual community perception and awareness survey. The board has seen that annual survey reported out relatively recently. And for quarterly reporting, we will also track some leading metrics such as engagement, our reach, and our impressions across our various communications channels. Moving on to the next key result, increasing non-tax revenue by 5%. This key result is about strengthening our long-term financial sustainability by growing revenue beyond taxpayer support, including patient care revenue, insurance premiums, third-party payers, grants, and fundraising. Progress against this OKR will be measured by whether total non-tax revenues grow by 5% over last fiscal year. Recall, we have this goal this year at 2%, so we're stretching. And we've defined non-tax revenue as total system revenue minus Central Health's tax revenue minus interest income, which is declining as our reserves are spent down pursuant to the board-directed healthcare equity plans. That's a bit of a confounder. Minus any one-time asset sales, such as the sale of the David Powell Clinic facility this year, also a confounder. So that's how we're defining non-tax revenue. Next, achieving 80% system integration. This goal builds on the system integration progress we made in FY26, where we were at 50% as our target this year. We're going to expand to 80% next year and push us further toward that goal of a unified operating team. Progress against this key result will be measured by the percentage of defined system integration goals completed by the end of fiscal year 2027. We will develop a comprehensive list of all of these focus areas and will assess whether they are appropriately aligned and or integrated depending on what is needed or appropriate item by item, and grade ourselves against the entire list, and we'll report that progress out on a quarterly basis. Finally, completing 80% of major milestones for critical infrastructure projects. FY27 will be a major infrastructure year for our system. Key milestones include our Hancock, Northview, and Colony Park campuses, and more. This key result is about making sure we can deliver on these major capital commitments in a timely manner. Progress against this key result will be measured by the percentage of completed infrastructure milestones for major capital projects by the end of the fiscal year. Milestones will include key project benchmarks such as contractor selection, groundbreaking completion, design plan approvals, and other key stepping stones, not just that final project completion, since it is a long chain of deliverables. That full list of milestones will be finalized, developed and finalized before the end of the fiscal year, and we will assess our progress against this list quarterly. So just going to that next slide of next steps, board approval of these OKRs will allow us to stay on pace with the budget development timeline. This is a critical input from which everything flows as we determine what is most important and where should we spend the limited additional resources as we grow. So once approved by the board, we'll do the work of ensuring all departments across the system are connected to these FY27 system OKRs, the vital few. We'll cascade them down through all of our teams, and we'll clarify the team-specific work that then enables us all to move as one toward these board-directed goals. So thank you again for your attention. We appreciate your leadership and look forward to your questions and hopefully your approval. Thank you.
Well, thank you. Mine is related to the quality metrics around the document that you sent. I have a few questions. Well, first a comment. If we are building a system, wouldn't you think there should be alignment in the quality metrics? Why should there be two different quality metrics based on where you receive care? Shouldn't it be all the same?
Hello, Tara Trower, Deputy CEO and Chief Strategy Officer at Community Care. Eventually, that is certainly where we would like to land. I think part of the struggle that we've seen this year as we've integrated is that we are counting things in different ways. Community Care is obligated as a federally qualified health center to use UDS. And so in the interest of being able to report consistently and give you all the data that you've been asking for, we would do these two data sets. I will say that there is a project in our environment so that we get better at HEDIS measures. It's not something that we're required to do, but we're working on. So that's certainly the direction that we're headed.
So can that be the metric that we start at least, the base, like work on the HEDIS, and if you cannot fulfill that metric, lean on the second metric that you have, the UDS, because it seems like some of the for instance, I'll give you an example. In terms of cervical cancer screening, the recommendation across ACS and all other major, guidelines is starting at age of 21. Here at Community Care, it's 24 to 64. So I think that's a missed opportunity. So that's like some of the things that's what I'm trying to see. I understand the challenges, but if we're trying to build something, wouldn't we want to be aligned with the major ACS and even with the U.S. Preventative Task Force guidelines or recommendations.
Good evening, everybody. Alan Chelsea, CMO, Central Health. I think it's a great point. The internal system for FQHCs is built on UDS, so they're mandated to report that. Some of their funding, the evaluation of the quality of the health center is based on UDS. The definitions are they're just slightly different. I don't think, if we look at an evidence-based approach, I don't think there's much difference between the two. The majority of the population that we serve, the majority of the population that we serve is actually going to be based on the FQHC. So using those UDS-based metrics is going to cover a broader population.
So even okay, another recommendation. Could you at least start with one metric to meet it and then build on as you're building, rather than the baseline should be UDS? So I'm just trying to think about, increasing access, increasing prevention, especially, we know that's a top killer in our community. So I would hate for us to miss a woman at a really, at a time that cancer lesion could have been easily treated beforehand and we can save a life. So I'm just...
We're certainly going to continue working towards that. I think the issue is information capture, not necessarily service delivery. I will let the doctor.
And if I can add in, regardless of how the measure is captured according to UDS tech requirements, we practice under USPSTF guidelines. So according to what the USPSTF recommends for screening, we use those protocols. Which portion of that is captured according to the UDS defined metric is a report out capability, but from an access and a quality service delivery to our patients, we are following the state-of-the-art guidelines.
Okay, and one last question. What's the age range of patients that you see at community care?
All.
The youngest, what's the youngest that you see?
Newborns.
Okay, so with that, I would actually recommend that we include HPV vaccination, because that actually, it can save, well, reduces cervical cancer, 6 types, cancers by 90%. So if that could be added as a quality metric for all our 4 clinics, because the guidelines is from age 9 to 15 and a catch up from till age 26 and optional till age 45.
Yes.
And if you get that dosing of vaccine, it can literally protect you 90% of those preventable cancers, and it can eliminate many. So
A core part of our vaccination program.
So at least that could be a metric that if we can include it in our upcoming OKR. So thank you. Those are my comments.
Thank you, Manager Kitchen. And then Manager.
Did you section?
Oh, I didn't realize there was more folks. I was just kind of.
Yeah, you can go too.
Yeah, and then I'll go around.
Oh, okay. Okay, thank you, Dr. Lee, for providing the measurements and the calculation. I would just ask that somehow or other we reference that on the page that we're voting on, so that we know this this document is what we're voting on. So, and that answers all those questions that I had about the measurements. I think, though, maybe we had a miscommunication about the last item I was asking for, because I wasn't asking for a measurement of related to mental health. What I asked for in the board meeting, and there was no disagreement from anyone in the board meeting, was just to add some kind of measure, whatever you guys think is appropriate, about progress on developing the mental health system of care. And that refers to the work that you guys have been doing with, with Integral Care and CUC, I think. It's the work that we reported on to the city and the county. It's just, and I don't know what the appropriate measure is, just to show us that you're making some progress on that. I know you've got work steps that y'all have developed. I would leave it to you to what the appropriate measure was. And when we talked about it in the board meeting, I suggested a couple different places you could put it, and left that also to you guys to figure out, you know, whether you wanted to put it under, I don't remember, I went back and listened to the tape, but I had suggested, I suggested you might want to put it under the access question, or you might want to put it under demonstrate value of community support, but that's your decision from my perspective, wherever you think it's appropriate. So I didn't hear, no board members said anything about disagreeing with it, about adding that in the board meeting. So we may have been talking about, we may have miscommunicated in terms of what I was asking for. So, because I'm not asking for a measure of mental health services, so.
Yeah, thank you.
Chair, which board meeting was that?
The last one when they presented on OKRs.
Yeah, when they
there was some
presented
feedback.
OKRs, that when we went through.
Was it a strategic planning? Oh, okay.
Yes, I'm sorry. It
Thanks.
wasn't a board meeting, it was a strategic planning committee.
Okay, well, yeah, thanks.
And Dr. Lee, do you need to hear more from us about that? Because I mean, I think in hearing Manager Kitchen, I think what I've heard is if you go back with your team about where to place
Yeah,
the progress on developing mental health system of care, in my because I'm used to like these metrics and measurements, that might not be the place, but where is the place?
Yeah.
Because these measurements are denominator and numerator denominator, but you might find that there's a place to put it, but I don't know if you. if you have
yeah,
any
exactly, because this one's not a numerator denominator. kind of-
Right,
It's
right.
more like some of these other measures you have on here that are not numerator, like you have demonstrate value of community support. That's not a numerator or denominator kind of thing, or system integration. But, so yeah, I would leave it to them to come back and tell us where's appropriate.
Although, and I'll just note that although I know that at almost every hospital here in Central Texas, all the EDs have been trained on mental health assessments, which are trying to get standardized in places. So that's not a bad idea to do that with our system and to allow the screening and then obviously then the access to those providers. But again, I'd love to hear from some of the other board members as well, just to make sure you're getting the clarity that you need. And if not, at the end of it, if you just let us know what it is that you need.
Yeah, and the reason I didn't ask for a particular measure like mental health assessments or things like that is because I know, well, first off, I didn't feel like I knew what was the right one.
Yeah.
And also, I know that the collaborative conversations that are ongoing, I don't know that they have identified something yet, so
Right.
that's why I didn't.
Dr. D, did you have a comment or I was gonna move?
Just very briefly, thank you for the clarification. Education is very helpful. I think for the OKRs in particular, since the intent is very much less is more in terms of providing focus for the team. Just for a matter of clarity, I think we would appreciate kind of a motion and a second and a vote so that we know that the board is directing, please expand the set to include X, Y, or Z, and then we will certainly do it. We just want to make sure we have clear direction from the board around where you want the focus to be, because it has such profound implications. The other thought, Manager Kitchen, to your point, Chair Rodriguez, there probably will be about 100 initiatives that we will take on underneath these 9 key results in order to drive these results. Much of the work that I think you may be referring to, Manager Kitchen, I want to make an assumption, would likely be captured in a lot of these initiatives. We find a way to connect with our partners, ensure people are not in the ED for preventable conditions, and so forth. And so, as you know, we work with Integral Care every week, and it is a vital part of the daily work that we do. Yeah.
Yeah, that's not really getting to what I'm talking about, and also, we're gonna vote on these entire OKRs, and so, there'll be a vote on all of the OKRs. I don't think we need to single out this one. But let me be clear about what I'm talking about. I'm talking about this major initiative that, that you guys have been working on together for well over a year. And you've provided us with progress reports during that year, as well as the county commissioners and the city. So simply continuing with what we've been doing before.
We'll go around and then and the manager may say, you went first, and I'm gonna go to manager May and then go all the way around.
Me, oh,
Please.
I may have gotten lost here, so I apologize. But when we were talking about the mental health piece, I wondered, CUC, they do, correct me if I'm wrong, but I thought you did some not you per se, Dr. Yogoda, but the team, that y'all do some preliminary mental health checks, or you're just giving referral information for mental health services?
We provide a substantial amount of mental health services. Our services on the spectrum of less complex to more complex disease is in the less complex area. On the other end of the spectrum, integral care handles the really complex cases. So we do an extraordinary amount of mental health daily. And probably at the end of the day, are one of the largest mental health providers in the region, but just because we're handling much of the low acuity care, preventing it from getting serious down the line.
So, again, I'm not sure, not too complicated, but I'm not sure that this would fit, but would it be appropriate perhaps to capture that data that is happening at the FQC level and using it as part of the OKRs, and that Dr. Lee can figure out a place where he's gonna put it? I don't know, I'm just looking for.
If you want to add that, that's fine. That was not my request, but I'm not opposed to it if you want to add that.
Because that
I
does get.
wasn't asking for outcomes measures, but, you know, I like outcome measures, so I don't have any problem with it if you want to add that.
For me, it gives us a number that we here, this board, can focus on where we got started, what it looks like, and then perhaps where it's going, and where we, as a board, might channel, if necessary, resources or channel appropriate guidance. I'm just throwing that out. And honestly, Dr. Yagoda, I'm gonna look to you because you're giving me this face, like you're trying to, I can tell you're trying to follow me. And I understand, I'm not trying to put you on the spot. But if it makes sense to you, what I'm saying, because you're in the field, you're practicing it, certainly don't wanna put anything on you guys that doesn't make any sense.
I appreciate the collaboration. There are a couple of measures that we use as standard practice. And again, this is to a point that I think perhaps Dr. Lee may have mentioned. We have a couple of core sets of measures. We have historically been based in UDS. Increasingly, we'll start to include other definitions of clinical quality performance in HEDIS and perhaps elsewhere. And those are well-established benchmarks for us to compare ourselves against other similar organizations. So we very strongly prefer to use well-defined, well-established measures to track our performance in a given space. They're not always perfect, and we admit that they're not always perfect. Some of them we actually don't like very much and are being contested at the national level. But they are useful for us because they're embedded into our workflows and easier for us to report out. And so we do have some in the mental health space that we could use if that was the preference. We have lifted up as a system what we feel like are the top priorities and feel like, given the circumstances, are very high value for what are the next steps in the evolution of the system. That is not to minimize any of the other measures out there. So of the many, many measures that are very valuable to different groups and to the whole, we have selected a handful that felt like they were in line with some of the major initiatives that were going to come on board with the future of the system, the near future of the system.
Thank you.
Thank you, Dr. Martin.
Yeah, Manager Kitchen, I think I'm kind of disappointed with Dr. Yoda saying primary care provides the vast majority of mental health care in the city. And I think that part of y'all do this as well. As part of like a physical examination, people get something called PHQ-9 or GAD-7. And I understand it's not perfect, but I think it's a relative measure of the success of the screening to some extent. And I think it's a quantifiable numerator denominator issue that we're addressing that issue, that we can actually measure the success. And I'd argue another point might be as a metric is, I mean, having an ER doctor, ED visits for acute mental health crises might be an OKR. That I think there's stand-ins for what you're,
I'm sorry, I couldn't hear you.
emergency room visits for acute mental health care crisis. I think those are stand-ins for what you're asking for, because I think it's very difficult to quantify a build-out per se versus looking at the metrics that we have. And I think the metrics in mental health, they're very, very vague to come to those answers. And I think that the data they're collecting, which PHQ-9s, those are proven good, okay screening tools to look at stuff. So I think what you're addressing is very good. But I think what they're trying to do is it provides us a good metric, what I think would be a good OKR for us to consider as an add-on. Because mental health is such a big deal.
Could I speak to that? So maybe the request is to unless you have one, unless you want to do these particular ones, maybe the request is for you guys to identify, I don't know, what you think are the most appropriate mental health measures, and to put that into the OKR. And I would just ask that these are the most appropriate mental health measures that can also show progress for us on the collaborative process that you all are going through, the initiative, and then there would be something quantifiable, but it would also show progress on the effort that you all are engaged in to create that continuum of care. And I don't know what that would be. I would leave it to you all to come up with what the appropriate measure are. And it sounds like Dr. Martin has some ideas about that, and maybe Manager May does too. So.
Did you have a question on this particular issue?
Agreed on mental health being a paramount concern and obviously an integral concern. And I have a question about the initiatives that we're referencing, or the collaborations that we're referencing. Have those been finalized or codified?
Yes, depending on what you mean by that.
Have metrics and goals been identified?
No. I don't think they're that far along.
Okay.
If you watch the presentation that Dr. Lee and Dr. Yagoda and Jeff Richardson made most recently to City Council Public Health Committee, and then in, I guess, December or so, to the county commissioners. I think they did a great job of laying out the scope of the project, and where they were in the process. I'd have to look to them. I don't think they've got
So is funding allocated, and is it like sort of operationalized already?
No,
okay.
no.
So I mean, to me, an OKR is about, okay, we've identified a needle that we need to move. This is a baseline, and this is where we need to go. There's really not much question about it. It's something we've been talking about a while, and we know that the initiative. I mean, I think what I feel like would be helpful would be to maybe disentangle the notion of the initiative coming to fruition from the OKR metrics, which are the indicators of this mission's success for this fiscal year. I think, if there is an initiative going forward and the board has voted to make that initiative happen, I mean, I think that's already, it's just an up or down thing. We just want it to happen, right? And the measurement would be, hey, because here's what I'm trying to avoid. When we have an initiative that, is conceptual, but, could be something that's latently operationalized, but not finalized, I feel like making it an OKR, i.e. an up and down referendum on whether or not we've achieved a core metric of success this year, risks, especially since it's not finalized yet, sort of maybe undue pressure on something that's not done. It doesn't seem like it's cooked out. Now, if it were a world where this initiative were to have been finalized, then we could say, okay, the shared goals that we hope to accomplish, there are in turn very clear metrics, that come from that, and they would tell us what those are. and we could, incorporate them into OKRs. Right now, what I might suggest is that this year we keep an eye on that, and we learn from it. We let the process come to fruition, and we keep our eye on that ball. We get a really good sense of what we think that baseline metric is for the following year, and if we think we can move the needle on it, how we think we can move the needle on it, and then incorporate it.
Can I add something?
Yes.
Manager Motwani, let me just, I probably am using the wrong word to use initiative, because I'm not talking about initiative in the way that you're talking about it. So let me just explain what I'm thinking, and then I really should let these guys talk, because they can explain it better. But it's not gonna be done. I mean, this is an ongoing process to improve the continuum of care for mental health services. And so what these guys have started doing and will continue doing is addressing those places in the system where patients with mental health crisis are falling. I forget the words that you used, Dr. Lee. It's really, they're falling through the cracks, between a referral, between Central Health and CUC or integral care or that kind of thing. So it's an ongoing process to identify that, as well as to identify the gaps in care. So it's a if I'm understanding correctly, this is a multi-year process. We're not gonna be done at the end of this year where we can
I think
look-
that's my point, yeah.
Yeah, so and we don't need to wait to be done to start measuring stuff. What I just asked these guys to do is to go back and identify some metrics for us that would be appropriate to measure, that would show progress on the work that they've done in terms of identifying areas where there's gaps in the continuum of care, identifying the things that they've already talked about doing, and I know you want to talk and I'll shut up, and identifying those areas, and just to show us some progress, because the last thing I'll say is that, the county and the city were both very excited about it, and I'd like to be able to show them some progress. So, I'm sorry.
So Manager, before we allow them to, I just want to get a check-in on the clarity here. So I think all of us agree that on the board that we would like from Dr. Lee get reports on progress on the developing of the mental health system of care. And I think if I heard you right, you're also asking, and can the team, Dr. Lee, or the leaders, can they go back and find some level of measurement that can be reported on whatever progress might happen this year or will happen this year? That's as I think, as Manager Musafir said, that's under our control, that has like all the parameters of what's required under an OKR versus, because the other thing was
that's
thinking,
what I'm
well,
asking.
do we put this in the performance review or in the weekly updates, or is it all of them? But I think right for this thing, you're asking about data, whether there is a data measurement.
Yeah, like Dr. Martin suggested, or, as a potential or
Right.
whatever.
I
And we
just
still
want to
haven't
get
let you talk,
clarity
I'm
with
sorry.
that. Thank you.
So-
And I'll let you all speak before we move to the next manager.
All right, Manager Kitchen, I think you're 100% correct. There's critical need for access to behavioral health across the care continuum. There's a lot of build going on. There's a lot of partnering going on. Could our initial metric be number of unique patients engaged in care?
Whatever you think is appropriate.
Because right now, as we build and as we collaborate, so we open access to care. And then as the systems become more sophisticated, so we can qualify what that means. But right now, there is a deficiency in access to care. And so that may be the first step.
You guys are the experts here, so I would defer to y'all to identify what you think is the appropriate measures.
Thank you, Manager Musafir, and then Manager Jefferson has been waiting.
On that note, I don't think it's the right place is here. I think it's more performance, and also I would like, I think a report. Where is the status on this progress, on this collaboration? Having all three parties here at present, I think that would be helpful. But also, thinking about what's within the data control within Central Health to perform, it's out of their control. I think one measure we can, these are evidence, these are national tools, the PHQ-9, the GAD-7, like those are really metrics that are accessible and that you currently are using. We should also estimate the baseline where they're at right now and measure them on a success of something they can control. I think what you are, which is a great, something that I'm definitely in support of Manage Your Kitchen, but I'm just trying to think of a way how to measure success of what's available within Central Health's control. I would hate for us to measure them on something beyond their control that others are involved in, because there's multiple parties involved.
Let me just say this, that's why I said that these guys are the experts, and they can tell us what they think is within their control. Measuring outcomes and numbers is how we hold accountability, and I think that we've been working on this initiative for long enough that it's time to start measuring whatever these guys have identified is appropriate. They're the experts, they can tell us, and I would not ask them to try to measure something that's not in their control. That's a very good point that you just made, but I think we can do that.
Very good.
I think that it kind of represents the notion of timing. I do think that there's going to be a time when we're ready with those baselines, and when that's intrinsic and natural for us to say. I think for now, for us to say, hey, we want to, what it feels like to me, and I know it's not like this, but if I were to be, I think just really simplified, it feels like we're saying, hey, we want to show moving the needle on mental health. Can you find some mental health stuff for us to put in the OKR so we can show that we're moving the needle on mental health? Which I think, yeah, it's well intended, but I think we can do better than that, and I think this process is going to help us get to where we can be, so we can do better than that. So it's a little bit more calibrated, precise. But then again, I'll defer to y'all in as much as what y'all think.
Yeah, I appreciate all the comments, particularly the permission that I'm hearing for us to think very deeply about what you are asking, which is we want to know that we're making progress on mental health space. A bit of background: we had the sort of agonizing and impossible task of trying to figure out what of a set of essential items do we pick to measure ourselves on. And candidly, with the hope of being able, every time we pick one of these measures, we go so deep into all the different drivers that affect the outcomes of these measures. It ends up creating many, many projects and bodies of work, and so it turns into very well-rounded approaches to improvement, and it's been very satisfying for our teams. We have tried to be very disciplined. Again, I'm being very candid. We've been trying to be very disciplined and select fewer this year than we have in the past, because less is more as we're building out the habits of an improvement culture within a integrated system. And so we did the impossible task of selecting two areas. We said heart care, cancer care. We chose those because they tend to be the highest drivers of mortality in this region, not because we feel like they are any more important than mental health. I think it is perfectly reasonable for this ask to come from the board. Please consider whether actually mental health measurement might be a top priority for this system. I guess my ask for you is, do we have permission to replace one of the others, or is the ask for us to do those three different bodies of work? Again, with the idea being that this is going to drive substantial amounts of cascading work down to the front lines. And I think it is a perfectly legitimate ask what is coming across, whether this is about mental health or not. But I just want to make sure that we are figuring out the breadth of work that we're being asked.
And I think I get what you're saying. I think and it's so difficult to understand if you're not a physician, that quantifying success in mental health is really a difficult metric, and so I think that some basic screening, which definitely it's easy to track, because
we have measures we can use.
And I think that has to represent to some extent a stand-in for success, that those things are being aborted, suicide, homicide, depression. I think that it's just such a difficult metric, unlike an A1C or cervical cancer screening. It's such a difficult metric to put your finger on and say, we're a success. And that's why I just said about the ER. But then again, we don't control if people come from out of town and are drug addicted and in the emergency room and psychosis. But I think that I think that's a simple metric. Would you agree to just screening as part of the thing anyway?
We have measures, and with your permission, I think we could come back with a recommendation of which ones work best across all the different entities. But I think my question in return is the ask to add an additional measure to the two sets that we talked about here, which in fact are 5 different measures. Do you want us to add additional ones, or is this a replace for one of those bodies of work? Yeah.
That's fair.
Oh, I think, yeah, that is fair. Manager Kitchen and then Manager Musatif, and then we'll move to Manager Jefferson and then Dr. Brinson, who haven't asked questions.
Well, I would just I would make a request also then. And that would be, so I can't answer your question. I would look to the rest of the board to see what they think about that, because I don't have a sense of the amount of work that's involved. I think Dr. Martin is asking something that maybe solves that, but maybe not, I don't know. But how would you recommend measuring progress on the initiative to, I'm not gonna use initiative anymore, on the work that you all are doing to address the gaps in the continuum of care for mental health?
I think given a moment, we could come back with a recommendation for it. I don't want to
You don't have to do it on the
overstep my
spot.
bounds, but.
You don't have to do it on the spot, and maybe you recommend that there's another process to do it in.
Sure.
Which is okay.
Yep.
If you don't think OKRs is the place to do it, I want to hear that, I just think that we need to measure progress, and so tell me how, and that's measuring progress where it's not just dependent upon, okay, maybe in this month we might go talk to the county commissioners, or this month we might, no, I want something more regular, so.
Thank you. Manager Musatif.
Mine is a quick comment. I think you're the expert, and we expect you to bring forth what is more evidence-based and what is best practice across. Thanks.
Manager Jefferson.
Moving away from mental health.
Well, okay.
It's important, but that's many folks around the table have much more expertise in that area, so I'll leave it at that. But I do have a question about the where is it? Care for Community and the metric on community awareness, favorability, and trust. And I think, Dr. Lee, I think I heard you say that you're going to be using the similar awareness study that we had heard results on. And I didn't hear whether something more, the awareness study that we received a report on before was good in terms of brand awareness, but not really on trust, or what I would just consider your basic customer service type thing, net promoter score kind of thing. And I'm wondering, would it be appropriate to use like just the metrics you have on utilization, number of people served for Care for the Community too? Because I think if people come, they must like it, or they're returning for a reason. So my request is that we just not rely on that same awareness study to measure favorability and trust.
Thank you. Manager Jefferson, am I understanding that the Net Promoter Score, which is a much more real-time assessment of did I find my care satisfactory today, kind of metric, that would be of interest for the board to track. And if I'm hearing correctly, this is actually one of the OKRs for this fiscal year, as you're aware. Community Care is doing an amazing job with that this year, and at the Strategic Planning Committee, we'll be bringing back a proposal for system KPIs, key performance indicators, which, as a preview of coming attractions, will include all of the metrics that the board approves in the OKRs and some additional metrics that are very important. So NPS, for example, might be one of those KPIs that we want to track, regardless of whether we're trying to drive improvement this year. We want to make sure it's definitely not backsliding. And so there's a set of metrics that we think are important that we may not be trying to drive improvement this year because they're doing pretty well. We want to make sure we don't lose sight of them. So I guess that'd be my thought, is that we would likely would have been planning to include a Net Promoter Score in the KPI set that we were going to bring back in a couple weeks. But I want to make sure I'm understanding your question. Yeah.
I guess that,
Yeah.
I thought we were being asked to approve this today, so there's more to these metrics. Okay.
These
All right.
these OKRs are the things that we want to improve. You know, we want to go well above where we are today. NPS should be 100. You know, would love to get, but actually it's 80, right? The NPS of 80 in a federal qualified health center is an extraordinarily high NPS.
Yeah, it
so
is.
to try to get to
Canadian
90 or
sector.
something is, you know, like if we maintain, 80 is a very high NPS. It's
Yeah.
crazy high. So that's
Canadian
partly
sector.
why we're thinking it's not a stretch goal to drive it further. We want to work on access, for example.
So, and then the other thing might be shaped by what you just said. So, you know, I have asked before under the Care for Central Health, the last section, system integration, to know what that encompasses, because it says percent of areas aligned and or integrated, suggesting that there's a list. And I just want to see the list.
Yes. We heard your request last time, Manager Jefferson. I forget exactly which backup packet is in, but we have a list of the current items that are being worked on this year. There are 20 of them that we've identified. And then heading into the next fiscal year, we would plan to produce a full inventory. We don't have them all named at this moment, but we would do that. And then I'll make it up. If there were 100 items on the list, then our goal would be to get to 80 of the 100 by the end of the fiscal year. And each quarter, we would report out against that list. But we don't have the list for next year finalized just yet. But that would be the intent.
Okay, well, I'd like to see this year's list, if there's
Yes.
a list for this year.
There is, yeah. And I don't know if someone knows exactly when that's coming forward. I've seen it. Okay, please. Okay. Okay, a little later would be great. Thank you.
Thank you. Dr. Brinson?
Well, I have a lot of views about this, but I think that it is probably best to leave it in the hands of Dr. Lee and the head of community care, because standards change and recommendations change, and what's important changes from year to year. And they get a lot of feedback that we don't get, you know, because they're nationally qualified health centers and all of that. So I feel I'm happy leaving that in their hands, and then, you know, we can go along with it as time goes by. And if there's just something that a particular one of us wants to know, you know, we can ask for that specifically.
Manager, just a quick time check. We're about 45 minutes behind kind of the scheduled time that you see on here, but I just want to make sure of two things. One, are there any other questions around the OKRs? And then Dr. Lee, too, did you get the clarity that you need about what to do here? And I think I have it on the agenda that we want to ask for a motion to approve these objectives, but I just want to make sure that if depends on kind of where the team is, but I see Manager Kitchen.
I will
raising her
include
hand.
the clarity on what I brought in the motion I make.
Okay. And then do you need any
I
other
think we would
discussion?
appreciate a motion so that we
Okay.
know clearly where the board is at. That would help us know what to do next.
Manager Mercedes?
With that, I think I would like to include the HPV vaccination to be part of this OKRs. And I think, you know, as Texas is lacking, it's behind the national, I think, metrics in terms of up-to-date HPV vaccination. So I would hope that at least, I don't know where community care is, the baseline, but at least from that baseline, hopefully by 20% of that baseline that you can increase up-to-date HPV vaccination. So I don't know, whatever you can is doable, but at least increasing that baseline data.
So in
Can-
general,
shall I make
asking,
it-
when Manager Kitchen makes the motion to have them consider a measurement to add around HPV vaccinations?
I'll add-
Well, it's usually measured by, so just really quickly. So with HPV vaccination, there's an initial vaccine, and then you need to be up to date depending on your age, the guidelines. So usually if you're under the age of 15, there's 2 doses that you need to complete, and that's called up to date. If you're over the age of 15, there's 3 doses. So that's really what I'm asking for, is the up-to-date HPV vaccinations, and that's the completion data. So I don't know what the baseline is, so I can't, the national goal is, the World Health Organization goes by 90% of the requirement is, but I don't know what the baseline data is for community care. So at least if we can bump that and continue on growing to hopefully meet 90% in the future.
Can I,
So you're asking them to explore that, because
Not to
because
explore. What we
they,
said,
because we,
appropriate measurement, yeah.
well, to explore what measurement we would take,
Yeah.
because I think as a board, I don't think we're dictating what the measurements are, but
So-
we're asking them to come back with a measurement.
Can I rephrase it? Can we at least increase HPV vaccination from the baseline data that you have right now? And then they can come back to us.
With a measurement around that.
Yeah, so whatever that baseline
whatever
is.
I'm be more comfortable with them to explore and to kind of advise on that. I just know that the controversy that kind of surrounded that one
Well,
some years ago. I just feel like, I just want us to have an informed, some context around that, and then we vote.
I completely understand, and this is probably something, and there is a lot of somewhat controversy, but it's the only cancer preventative vaccine available. And I think if we market it and knowing that cancer is killing our population, if there's a way that we can save them, and with this vaccine, they're 90%. There's 90% or more reduction of cervical cancer, and also it's good for boys and girls. So that is really, it's data driven. It's data driven and it's an issue, and if we are thinking about just screening, we need to also think about primary prevention. So at least to increase HPV vaccination at our community, at our clinics, that's what I'm asking for.
Could that fold into the heart and cancer care measurement under the heart and cancer care KR measurement? Could it just be codified under there? It's a what? It's a different measurement. It's a different measurement, yeah, for sure. I mean, but it would be a different, like, so heart and cancer care has I think a smattering of measurements, right?
Well-
So could we include HPV
I think that-
vaccination? I don't know if it's appropriate to include it under cancer care
Well,
per
this
se.
whole discussion
but anyway.
is exactly why we
Wait,
want to make sure that we ask them to come back.
fair enough.
with
Oh, yeah,
that
yeah, thanks,
subject.
thanks, Chair.
So, Manager
Are
Kitchen,
you
will
ready
you?
for a
Yeah,
motion?
I am.
I move that we adopt the fiscal year 2027 system objectives and key results, the OKRs, as laid out in our board packet with the following additions. The first addition being that we will incorporate the measures shared with us today by the document that was handed out. Doesn't have a name on it, that's the best I could do. No, not mine. The document that Dr. Lee passed out that describes the measurements. The second is that we recommend, second is that we request that Dr. Lee and his team recommend an approach and/or metrics to report progress on developing a mental health system of care. And then the third is that we request that Dr. Lee and his team recommend the metrics to measure up-to-date HPV vaccine. If I got that right. Okay. Did you guys get that,
So
David?
that's,
Sure. The
oh, if you
third-
could repeat the third one.
The third one, and I'm looking at measure recitatives, that Dr. Lee and his team recommend the appropriate measure for up-to-date HPV vaccines.
Do you want to clarify?
Is that right?
Yes. So, sorry, I'm losing my train of thought. So, if this helps as a metric, so nationally in Texas, up to date in 2023 is roughly under 58%. So I don't know if that's another
I'm
relevant.
not adding that to the
It's not
motion.
adding, I'm just giving you for context reference. So well, what you said, it primarily is to increase HPV vaccination within our system, if that's helpful.
Yeah,
Second.
yeah.
Okay,
So we have a motion and a second,
okay.
and any discussion? All those in favor of the motion, raise your hand.
Aye.
The motion
Aye.
passes unanimously. Thank you, Dr. Lee. We're gonna manage, I think the next two are probably gonna take less than 20 minutes, if that. And we're gonna move to item number 4, the review and take appropriate action on the policies necessary for FY '27 budget development process. And Nakia Smith is presenting, and I think as a reminder, I think Nakia will check me on this, but I think we've done these reviews at our executive committee. We went to our board meeting, had some more edits, and I think you have 2 that you wanna highlight on the edits, and I think everything else, there's been no other updates or feedback from the board. So I think after Nakia presents, I'll open it up for any questions, and then, and if there's no questions, I'd welcome a motion. Thank you.
Yes, good evening. So that is correct. So I'm presenting the revised policy supporting the fiscal year 27 budgeting process. We made revisions to the annual planning, annual budget, and the financial reserves policy. The main changes to all 3 policies were the delegation of authority language that's been updated across all of them. And then we made minor changes to the financial reserves and the annual budget policy, and they were very minor. We did not receive any additional feedback after our last meeting, and so those were the actual respective changes. If there are no further comments, I'll ask the board to make a motion to approve.
Manager Kitchen, and then Manager Mercedes.
I just have one comment on the planning. I think it would be more appropriate at this point to uncheck the boxes for Sendero and community care at the top. And I apologize, I didn't notice that before. And that's because we either have to fix the language or uncheck them. Because the annual planning draft refers to a number of things that don't account for CUCs or Sendero. I'm not as familiar with Sendero, or Sendero's role in the process that they take in planning. So I couldn't come up with a sentence or two, so that's why I thought let's just uncheck them at the
Okay.
moment.
We'll make the changes to the header
Okay.
template.
Members, anything else? Any other questions?
Can I make a motion?
Yes, but including what they just,
Oh,
what
why
we
don't
just,
you make it then?
Okay.
you have a motion?
I move passage of annual planning draft with the addition of unchecking the boxes for Sendero and community care.
And the annual budget and financial reserve.
In the
fund?
annual planning draft. Annual planning policy.
So just the first one, not all, not the
Oh,
other two?
well, oh, did you want me to go through all of them? Oh, okay, sorry. I'm
Yeah, sorry. There's 3, sorry, members. Annual planning policy, the annual budget policy, and the financial reserves policy.
Okay, I will change my, okay. I move approval of the 3 policies, the annual planning draft, annual planning policy, the annual budget policy, and the financial reserve funds policy, with the addition of unchecking the Sendero and community care box on the annual planning policy, and unchecking it on the annual budget policy, for the same reason I mentioned before, but not the last one.
Got it. Not financial services.
Yeah, not financial reserves.
Members having a motion, is there a second? Manager Musaidov seconds the motion. All those, well, is there any discussion? Yes, Manager.
And Chair, if you can answer it, great. Am I missing why the boxes were checked originally and why we're unchecking them now?
I think Manager Kitchen can explain.
Well,
that.
I'm not as familiar with Sendero, so you may want to change what I just said, but I know that for CUC, those first two policies do not reflect some of the language that's applicable to annual planning and annual budgets. So we either need to add their language, that particular language, which I didn't want to slow this down, or we need to uncheck the box with regard to community care. I haven't done the homework I just assumed that it doesn't say anything about Sendero either, so
Oh, and so these are new policies?
we've talked about them many times,
Yes.
yes.
Okay.
Yes.
They're
Okay,
new.
but meaning there wasn't a previous state, yeah, no, thanks. Thanks,
They're new.
thanks.
No, and as and last part of the discussion is that as we move to approve these policies, and I would say Dr. Lee or the administration, if you find out that we need to add back Sendero and community care and there's appropriate language, or just that we need to do that, just let us know, we'll put it back
Yeah.
on the agenda.
Yeah, I don't have a problem with that, it just
Yeah.
doesn't have the right language in it.
Yeah.
So,
Jeff, did you have a comment, or we're good? We're good? Okay. Managers, having a motion and a second to approve the three the three revised policies supporting the FY27 annual planning and budget process. All those in favor?
with the unchecking.
I'm sorry, with the amendments made today.
Okay.
All those in favor, please raise your right hand, or raise your hand. And the motion passes unanimously. Members, we're gonna move on to item number 5, receive and discuss an update of the Central Health Hancock Center building project. I think Stephanie McDonald will be presenting. I think originally this was a 20-minute item. I think we shortened it to 10 minutes, and seeing if you have any questions. 2 minutes, sorry, 2 minutes. Plus questions, I don't wanna leave out the questions.
Sometimes stars align, and I think many of you, thank you so much to the managers who made it out last Friday. I heard Pat use the word exuberant. It was a wonderful, joyous day, but this is just phase one. I want to be very clear that this was just a portion of the facility, that we have a much bigger actual grand opening we hope planned for the early next year. If you can go to the next slide for me. Some pictures from the event. I think you'll see more of these in the coming weeks on our social media platforms. I am very excited to report that we are on track. This was an ambitious plan where we divided the building into 2 separate projects, 2 separate permits. So the phase 1 allowed us to relocate the David Powell Clinic in advance of TxDOT taking over the current David Powell facility, and not having to move the patients more than once. So we are really thrilled. It's been a pleasure working with this team across both community care and Central Health, and I think we've done a lot of work very quickly to integrate the organizations. Next slide, please. I think there were some questions about, well, what's coming up for the building and the facility. We do have first patients scheduled for 10 a.m. on this Friday for David Powell. We've had patients already stop by, really excited about getting care at the new site. On May 18th, we are scheduled to relocate the Capitol Plaza Convenient Care. We still call it Hancock Convenient Care, actually. That practice will move back into Hancock, into the old Sears building. We will have in the future an adult IM practice as well. The community care will bring into the Hancock Center. The goal right now is to start, having substantial completion on phase 2 and the rest of the facility later on in this calendar year. We do hope to relocate the team that is at Airport Boulevard into this facility. The goal is 1 move for everybody, not multiple moves, but we, of course, are always dependent on the schedules and supply chain and all of the other factors that go into a construction project. And then we hope that we can have all the clinical services as well as your board meetings and the administrative offices online and into the beginning of 27. So look forward to that. And if you'll go to the next slide for me, please. This did go out to you all yesterday, and this is something that we were in discussions with Chair Rodriguez as well as Vice Chair May. Just so you know, we did walk the site this morning. Manager May came on Friday, Chair Rodriguez this morning. We are happy to take anybody else who wants to go down there. Just let me know. And if you have specific questions, we don't want to overshare necessarily, but if one-on-one, happy to answer any questions about egress and then this kind of details a little bit more about where the public auditorium where the board meetings will be held, sits in relation to the rest of the facility, access points in and out, where and there is kind of a front of the house, back of the house function that I'm happy to walk you through. It is still a construction site, so if you do come, just know that you need to let us know that when you'd like to come, and I think the team here will help set that up with me. Closed-toed shoes, you'll have to wear a hard hat. We make sure that we take your picture in the hard hat. That's one of the rules about visiting the Hancock Center at this time. I'm happy to answer any questions. I'm also happy to meet individually and tour with all of you. Thank you.
Thank you, managers. Any questions? I'd really encourage you all to go and do that. I think I might have to go a second time since I didn't get a picture with my hard hat.
Yes.
Neither did I.
Yeah, manager was saying.
No, thank you so much, Stephanie. I really appreciate it. So I will expect some communication from you soon. Thank you.
Thank you very much. I'm sorry, Manager
No,
Mercedes.
just Stephanie McDonald, Chief Infrastructure Officer, you know. That's all I gotta say. What's that?
Members, and thank you again, Stephanie, for that. Members, I want to announce that the board is convening in closed session to discuss agenda items 6, 7, and 8 under Texas Government Code 551.071, consultation with attorney, and that's item 6 is receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Dr. Patrick Lee, cause number D1GN 17005824 in the 345th District Court of Travis County, and services provided by faculty and residents of the University of Texas at Austin Dell Medical School in support of Central Health's mission. Item 7, receive and discuss a briefing regarding Travis County Healthcare District doing business as Central Health versus Ascension, Texas, frequently known as Seton Healthcare Family, cause number D1GN 2300398. And item 8, receive briefing from staff and legal counsel, consider any settlement offers and take appropriate action regarding possible negotiation and settlement of potential litigation claims involving the district. And then agenda item number 9 under Texas Government Code 551.074, personnel matters, that being approving the president and CEO's goals for fiscal year 2026. And agenda item 10 under Texas Government Code 551.074, personnel matters, and Texas Government Code 551.071, consultation with attorney, for item 10, deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. And the time is now, it's still April 22nd, 2026, April 22nd, 2026 at 7:49 p.m. Thank you. Good evening. It is April. Oh, my phone just shut down, sorry. My battery went out. Yeah, there it is. It is, good evening. It is now Wednesday, April 22nd, 2026 at 10:01 PM, and we are entering open session. And I'm going to recognize Manager Jefferson for a motion on item number 8.
I move that we delegate to Dr. Lee settlement authority on the King matter as discussed in executive session.
Do I have a second? Having a motion and a second to approve the motion on item number 8. All those in favor, please raise your hand. Aye. And the motion passes by all of the members present. I'm going to recognize, who's doing number 9? Is that the Manager Jefferson? A motion to approve.
I think I'm doing 10.
Who's doing number 9? The approval of the President and CEO's goals. Okay. It's on the script. Number 9.
I move that the board approve the president and CEO's goals for fiscal year 2026 as recommended by the, was not as recommended by the executive committee, it was also modified.
As modified by us.
As recommended by the executive committee and modified by comments from the board,
From the Board of Managers today.
board of managers.
Do I have a second?
Second.
Having a motion and a second to approve the President and CEO's goals for fiscal year 2026 as amended by the Board of Managers in this meeting. All those in favor, please raise your hands.
Aye.
And the motion passes unanimously.
I'm a nay.
Oh, I'm sorry. And and Manager Motwani is a no on it, right?
Thank you.
Negative, no. Okay. So the motion passes 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 6 voting yes, 0 abstentions, and 1 no. And that being Manager Motwani. I'm now going to recognize Manager Jefferson for a motion on item number 10.
I move that the board signifies support for the item discussed in executive session, number 10, as discussed in executive session.
Thank you. Is there a second?
Second.
Having a motion and a second on item number 10, all those in favor, please raise your hands. 1, 2, 3, 4, 5. All those abstaining? Show Manager Motwani abstaining, and all those opposed? And show Manager Martin opposed to that. Okay, so the motion passes 5-0. I'm sorry, 5-1-1. Yeah, thank you. Manager, our next regular Board of Managers meeting is tentatively scheduled for Monday, April 27th, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. And at this time, I'm ready to accept the motion for adjournment.
So moved.
And second. Manager Motwani, second. So having a motion and a second to adjourn, all those in favor?
Aye.
Aye. The motion passes unanimously, and we are now adjourned at 10:04 p.m. Thank you all.